Good afternoon, everyone. Bancroft Neuro Rehab welcomes you to our Heads Up webinar series. Bancroft Neuro Rehab is a premier provider of post-acute neurologic rehabilitation, offering residential and day services, neuropsychology, and outpatient therapies at 3 locations throughout southern and central New Jersey: Mount Laurel, Plainsboro, and Toms River. Bancroft Neuro Rehab is a division of Bancroft, a provider of programs and services for people with autism, intellectual disability, and other neurological conditions. Today's program, The Psychology of Stroke, will be presented by Dr. Claire McGrath, Clinical Director at Bancroft Neuro Rehab and a board-certified neuropsychologist, as well as Dr. Tiffany Channing, who is a neuropsychologist here at Bancroft Neuro Rehab. We also have special guest Brian Propp joining us today as well. Now I'm going to turn the presentation over to Dr. Tiffany Channing to get us started.
Thank you very much for joining us today for our presentation regarding the psychology of strokes. We are very excited to be talking about this topic with you all, as when we typically think about strokes and recovery, people usually think about changes to physical functioning or language-related functioning. What Dr. McGrath and myself are going to be focusing on instead today is the concept of how there can be a psychological and emotional component involved in strokes and recovery, which can either be reflective of neurologic changes or due to general adjustment to the event. And to start us off today in better understanding the psychological recovery from a stroke, I am very pleased to introduce Brian Propp, who will be sharing his personal story of surviving a stroke and getting back to the game of life. So Brian, whenever you're ready, you can take it away.
Well, good afternoon, everybody. Welcome to the webinar. I'm Brian Propp. I grew up in Canada, Saskatchewan, where it was really cold. So I learned to skate a lot. And when it was outside, my dad was a Lutheran minister. I have 2 brothers and 2 sisters. We're all 13 months apart, so we had our own hockey team. And we needed to because we only had 300 people in the town. So you had to find a place just to skate where I wanted to. But so I just got drafted when I was 19 years old. I got drafted by the Philadelphia Flyers. And so I started with them right away. I played 11 years with them, went to the 3 Stanley Cup finals with them, 1980, 85, and 87. And then I played for Boston and was in this Stanley Cup finals in 91 and 92 with Minnesota. I was in the Stanley again. So I had a lot of experience playing in the playoffs, and which is the good, fun time of the time. And but you know, just for me, like it just playing for 15 years and being an all-star, it was wonderful for me. And but I just wanted to thank Bancroft because I've been their ambassador the last 3 years, where they do so good with all the people that they have, and I'm really happy helping other people with all of that too. And plus, I work with Wolf Commercial Real Estate in Marlton and PA. And so I'm usually with them, and we do a lot together with them. We have a golf tournament on June 15th. Bancroft will be as one of the 6 charities supporting us. And so if you want to play golf, that's great. And if you can sponsor, that would be great too. But I just wanted to talk about my stroke because I had a massive stroke in 2015 of September 3rd when I was on vacation with my family in Annapolis. When I was checking out a score for my son Jackson at the Navy Academy. And so the first day, we just rented a house for a couple of days, and the first day I was okay. But the second day I had a really bad headache, and I stayed in the rented house. And so that night, like at 1:30 in the morning, I fell out of bed, hit the side of the bed, hit the side and lost a couple teeth. All those years in playing hockey, I didn't lose any teeth, but I couldn't talk, I couldn't walk, I didn't know what I was doing. So thankfully, my family was there to call 911 pretty fast, and it probably saved my life because I couldn't talk at all, and didn't notice it, but it was really scary at that time. I didn't know what was going on. I didn't know if I could ever talk or walk or do anything again, and so it was really tough at the start. And so for 6 weeks, I did in the hospital every day, and then 3 hours of occupational therapy and physical therapy and speech therapist. But the speech was the toughest because I couldn't say anything at the start. At the start, the only two things I could say was and Bernie Pront. It just came out. I don't know. Not even my family's name. But after time, I did some outpatient for 5 days for another 1.5 years, and so it took me a long time to get much better. But now I've come back a long way. I still have aphasia with my speech, and but Bancroft has helped me because I went to them for Bancroft for occupational therapist, physical therapy, and speech therapist again, because you always have to keep up with the rehab. It's been 6.5 years since I've had my stroke, but can you imagine not even talking? And the only thing that I have is that my right fingers and the right side still don't work, but I kind of hide that every once in a while. So I have to sign with my left hand now, and I can't throw a football or a baseball, so like it's just little things that you don't notice, but for me it was a struggle at the start, but I had a positive attitude, and so I knew that I could be much better after time. But the people at Bancroft have done a wonderful job, and so like I really like what they've been doing, with all the things that we do, the webinars like this, and from speaking, and like, we have a golf tournament in November 3rd or 4th. I'll be there again and supporting that, and so it all comes along to be really, really good. And I just want people to know that stroke doesn't have to end right now. Like it'll take time for your brain to heal and get a little better. So I knew that after time, like I had to be patient, accepting of my disability, and again patient, and so that gives people a lot of hope to get better. And so I'll stop now because I love life. I'm the happiest guy in the world every day, and I wake up with a smile. Like this morning, I skated at Pennsauken Skate Zone with a group of guys that I've known for 25 years, and so 2 goalies, 5-on-5, a couple subs, and I scored a goal. So I did a guffaw when I scored. So that makes me happy.
Well, thank you so much for sharing that story with us, Brian. It's so, it's an inspiration to hear you talk about your experiences. And I want to say how grateful we've been working with you, because we can talk with people about stroke, but to have a stroke survivor, someone who says there's life after stroke, it takes hard work, but you can get better. It's a huge influence on people. So we're so grateful that you've been working with us. We had a few questions that we wanted to hear a little bit more about from you. One of the things that I was wondering if you could talk a little bit more about any emotional or behavioral changes. Did you have any changes in your emotions or behaviors after your stroke? And if you did, how did you overcome them or cope with them?
Yeah, so at the start, like I was really frustrating because I couldn't talk at all. So like I remember when I was in the hospital at the start, a friend of mine, Scott McKay, like he visited, and like I couldn't talk, and so I had to point and try to talk, but it wasn't coming across. It was like I was trying to say computer because I wanted my computer. And so, but he didn't know, and it was frustrating for him. So for me, like, it was really tough at that time too. So like, it was like charades. You have to kind of act it out. But you know, after time, the speech therapist made a big difference. And so the best thing that I did was read a newspaper out loud. That really helped me, because saying the words, and I still have trouble with names and math and a little bit there, but you just had to be patient. But you know, I wanted things to happen to go much faster at the start. And so, like, of course, you know, you get upset if you don't move faster, but I learned after a couple of months just to relax and be a little bit easier with thinking about life, and let the brain heal a little bit more. Like, it's a slow process. And so I tell people at the start, just, you have to really be patient at the start, because like 6 months, it makes a big difference. And with the right help, the people will help you.
I think that's a great point, Brian. I know that Dr. Channing and I have found, when we work with people with a stroke, they want to get better faster than they are, and having that patience and being able to stick with it is really important. So I think that's a really good point to make. So right after your stroke, I would imagine, so there's a big focus on your physical recovery and your speech. And I would think, especially because skating is such an important part of your life, that therapy was focusing on your physical functioning. How important was your mindset, sort of having a positive attitude on your recovery? How important was that, do you think, for you?
Well, I think it was really important, because as an athlete, you learn how to train your body to do the same thing with regular routine, and just never giving up, and being healthy with your living. And so, like, that made a difference for me, because you know, I'm still the same weight as when I played hockey at 188, and still I haven't gained much weight, and but I stay very active. Like, I walk a lot on the beach in Florida, and you know, and I stay really busy with Bancroft and Wolf. You know, just your brain has to really kind of make sure that you're doing things like that too. But for me, for playing hockey all those years, it gave me an advantage, because you're always looking for something new to get better. And I know when I played in the 80s, I had a sports psychologist, Steve Rosenberg, who helped me about relaxation and the brain, how your brain works. And I did a tape of like 20 minutes where I really relaxed, and it really helped me with when I got into playoffs. But after a stroke, you know, sometimes you forget about that, and you always have to look for some way that you can get much better. I know that you know, I've done a lot of different things, and look for a couple of different things that you can try to get better. And thankfully for me, I've come a long way.
So it sounds like, you know, that's an interesting point, that being an athlete, you were always a person pushing yourself to improve. And then after your stroke, you kind of carried that through. Is that right? Just looking for new ways to get better is something that's been really helpful for you?
Yeah, especially you know, because for me, like I mentioned, like, my right fingers and the right side didn't work, and so, like, but my feet were okay. Like, I didn't have to, like a lot of people that have the left or the right side strokes, so, like, they have trouble with their legs, and after that, but I always had good balance. And my physical part went really much faster than the occupational therapist and the speech therapist. Took a lot longer, but it just by sticking with it and trying to figure out a way to go, and I know, like, for me, when I got back to skating on the ice after a year and a half. That meant a lot for me, and plus Bancroft did a really nice video of me recovering, and they won a couple of awards with that. And so like, but it was like I said, just skating this morning with a group of guys. Just happy to be out and talking and having fun and being with them, like, you know, because a lot of people have strokes like are by themselves, and so like it's tough if you don't have other people that you can do some things with, like even rehab. You give them that time, and a lot of people stop it after time. And so I tell them, no, don't ever stop. Just always look for a way to get better.
I think that's excellent advice. I'm going to write that down so I suggest it to people when I work with them, because I think you're right about that. So you have mentioned that there's some deficits, some difficulties you still have. You said your right hand is numb. You still have some difficulties with speech, but you're certainly a great speaker. So what are some of the difficulties or deficits that you still have 6 years after your stroke? And how do you work through them?
So I know a lot of times I go to a lot of events, but the last couple of years, because a lot of things are virtual, like it was a little different, but I like going out with people and talking with people. You know, of course, like for me, like if it's loud in a room, like I have to back down a little bit. I have to just take my time and just kind of go away where it's a little quieter, because you have to be bothered by if it's too loud for me. And so like that was one problem that I really had. And but you know, you learn to just, hey, listen, go in another room and just sit by your side, and if it's too loud. And with names and math, like I always carry pictures with me, and so that people can sign. And so like I have to ask them if what name do they want, but I have to tell them to spell it out for me, because it's a little tough just thinking about how the name is, and because there's different names. But I always ask people to ask, tell me their name, and then I'll drive it, but I have to do it slow, because you don't want it to make a mistake. But for me, it's just been, just with being out a little bit more and talking to people, I don't have a problem with that. I think that my speech has come a long way, where if I'm relaxed and take my time, it comes along much easier. But if you get rushed and you're thinking about it, you kind of get messed up a little bit. And so, but for me, it's just been all the support from Bancroft and my family and friends and Flyers alumni. Like they know that there's a lot going on, but I try to be happy, and I always am. But it takes some time, and like there's just a couple things that I've noticed that haven't worked. Like in just physical, like my right hand doesn't work that well, so like I have to kind of carry things, and kind of drop it every once in a while. But you don't really notice it, because when I was the Flyers ambassador 4 years before hockey was on, and then the last 2 years, like it's not. But I was at every home game, and so I got to meet other people. It just took me a little time to get dressed in, because I usually wore a suit, and I couldn't bite in a ship and tie shoelaces, and so it's just you just have to take your time and just try to get there early, and be prepared.
Well, that is just excellent advice, really. It's so wonderful to hear your input and to hear how you've remained optimistic and really grabbed onto these strategies. I think that's wonderful. So thank you again for taking time to answer some questions for us. We really appreciate it. And what we're going to do now is Dr. Channing is going to start us off with a more formal lecture talking about what a stroke is, and then we'll talk about how it affects psychology and mental health following a stroke. So thank you again so much, Brian, for all that really valuable input.
You're welcome, and guffaw!
Yes, thank you so much, Brian. And additionally, if anyone in the audience has more questions, specifically for Brian or Dr. McGrath or myself, I encourage you to hold on to these, as there will be time at the end of the presentation to answer these questions. Okay, so both Dr. McGrath and myself have nothing to disclose. And following our presentation, you will be able to describe common neuropsychiatric symptoms that occur within different stroke syndromes, identify risk factors associated with post-stroke depression, recognize factors that affect recovery from post-stroke depression, and describe interventions associated with psychological recovery and adjustment following a stroke. So starting us off, I want to define what a stroke is. So according to the American Stroke Association, a stroke is a disease that affects the arteries leading to and within the brain. It is the 5th leading cause of death and a leading cause of disability in the United States. The American Stroke Association also provides further definition in that a stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is either blocked by a clot or bursts. When that happens, part of the brain cannot get the blood and oxygen it needs, so it and the brain cells die. So essentially, when a stroke is developing, that specific part of the brain is not getting enough adequate nutrients, in particular that oxygen and glucose, and as a result, the blood supply is disrupted. And then after several minutes of not getting enough blood supply, the infarction actually occurs. In addition to the death and damage of brain cells, other medical complications such as seizures may also occur. We should keep in mind that with a stroke, if blood supply is restored within an appropriate amount of time and the stroke is caught early on, brain tissue may remain viable and function can recover. Additionally, there are various aspects to keep in mind that influence the type, extent, and symptoms of a stroke, including the size of the blood vessels, degree of blood vessel weakness, and capacity for compensation by surrounding vessels, if there are pre-existing lesions, where the location of the lesion is, and the rate of symptom development. So there are a lot of different factors that are involved which can impact stroke symptoms and recovery. Broadly, when we do think of strokes, there are several different types. Starting off with the obstructive ischemic stroke, this type accounts for 87% of all strokes. They can occur rapidly over hours, days, or episodically. And what happens during this type of stroke is that a blockage of a blood vessel can occur when a clot travels from a different place of origin and becomes lodged along the way in the cerebral artery. There are several different causes for why this can occur. Two of the primary causes are atherosclerosis and atrial fibrillation. With atherosclerosis, this refers to when there are fatty deposits lining the vessel walls. And then atrial fibrillation is referring to having an irregular heartbeat, which can cause clots to form in the heart, which then travel to the brain. Two types of obstruction or blockage can occur, as you can see listed up here. So the first one is cerebral thrombosis, which is a thrombus or blood clot that develops at the fatty plaque within the blood vessel. The second one is a cerebral embolism, which is a blood clot that forms at another location in the circulatory system, usually the heart and larger arteries of the upper chest and neck. Part of that blood clot then breaks loose, enters the bloodstream, and then travels through the blood vessels until it reaches a vessel where it's too small or too tight to get through. Hemorrhagic strokes involve massive bleeding in brain tissue due to a weakened blood vessel rupturing. This can be due to hypertension, congenital cerebral artery defects, toxins, and blood disorders. The most common cause is uncontrolled high blood pressure. Two types of weakened blood vessels that usually cause hemorrhagic strokes are aneurysms and arteriovenous malformations, which are also referred to as AVMs. An aneurysm develops from a weakened area in the wall of a brain artery, and over time that weak spot can grow and begin to balloon out from the artery and rupture. The AVM, in contrast to that, is when there is a tangle of abnormal blood vessels that connects the arteries and veins in the brain, which then ruptures and causes a bleed. An example of this is shown in the visual on the right here. And then lastly, transient ischemic attacks, or TIAs, which are also called a mini stroke, are brief events that last for a few minutes to a number of hours, and they typically reverse themselves either abruptly or gradually. This is more commonly associated with atherosclerosis or hypertension. What's always important to keep in mind here is that while these are considered mini and may resolve, it can be a warning sign for an actual stroke occurring and coming. In addition to thinking about what are the different types of strokes that can occur, it's also important to take a step back and understand the vascular system, as this gives us the foundation of identifying where strokes can occur and why certain symptoms are happening. So this pictorial up here gives a nice overview of how the blood travels throughout the brain. The blood supply to the brain is transported by two internal carotid arteries and two vertebral arteries, with both vessels entering on each side of the body, and this can be broken down into anterior and posterior circulation. With the anterior circulation, so we start down at the aorta, which you can see at the bottom there, that then rises up into the common carotid artery, which then eventually splits and goes between the internal and external carotid artery. The internal carotid artery branches out to form these two large arteries, the anterior cerebral artery and the middle cerebral artery, in addition to a number of smaller arteries and branches which travel throughout the brain, such as the ophthalmic artery, which then feeds blood into the subcortical regions of the brain. The anterior cerebral artery and middle cerebral artery provide the blood supply to the anterior and middle regions of the cortex, which will include the frontal lobes, temporal lobes, and parietal lobes, which I'll be talking about more as we go through the different stroke syndromes. With the posterior circulation, the vertebral arteries similarly enter at the base of the brain and then join to form the basilar artery, which gives off these smaller arteries and then branches into the posterior cerebral artery. This supplies the spinal cord, brainstem, cerebellum, and posterior diencephalon. The major branches within the posterior artery also branches off from the vertebral system and supplies the lower surface of the temporal lobe and large areas of the occipital lobe and the visual cortex. This is another view of the vascular system, as you can see kind of weaving throughout the brain here. And what we see on the right is the circle of Willis. So the interconnection of all the arteries that I discussed and the anterior and posterior circulations meet to form this ring, also known as the circle of Willis. This circular connection can help compensate for the half of the brain that has lost its blood supply if the blockage is only occurring on one side. So then we have the last piece of the puzzle here that gives us the foundation for understanding strokes, which is the neuroanatomy, where what we're doing is recognizing that different brain regions are in charge of different areas of physical, cognitive, behavioral, and sensory functioning. So this is broadly identified up here in this visual. So when you look at this picture, I want you to also think about the picture we looked at for the vascular system, and then think about where that blood supply is going. And if that blood supply is interrupted to that part of the brain, then we would typically expect to see a specific type of deficit or symptom cluster related to what that region is in charge of. Given that Dr. McGrath and I are focusing on the neuropsychiatric symptoms of a stroke, I also wanted to highlight some specific portions of the brain. So the frontal lobe, and particularly the prefrontal cortex, which can be divided into further separate regions, is very important to think about in terms of emotion and behavior. Typically, when we think about frontal lobe functioning, we think about executive functioning. So being able to solve complex problems, plan ahead, regulate actions, shift behaviors after taking in feedback from the environment. Additionally, the functioning within the frontal lobe can involve a motivational component, as well as helping out with things like inhibition, judgment, and insight. So then when we think about if the blood supply has been disrupted to these areas, we would expect to see some deficits there. So someone may be more concrete, have difficulty with flexible thinking, they might be more perseverative and get stuck on tasks, thoughts, or behaviors. They might lose spontaneity, curiosity, initiation, or develop more of an apathetic blunting of feeling, drive, and behavior. The individual might also experience impulsivity, social disinhibition, loss of judgment, and loss of insight and foresight. And while I am talking about the frontal lobe specifically right now, you also want to consider that there are various circuits and pathways that run throughout the brain and connect to different brain regions, which can help explain why even if there's not necessarily a lesion or a stroke within the frontal lobe, you still may see these symptoms or changes that appear to be frontal lobe dysfunction. An example of this too is that the prefrontal cortex has these interconnections with the limbic system, which includes the amygdala, and thus plays a really large role in emotions and behaviors as well. So now that we have the whole picture together with the vascular system, brain neuroanatomy, and functioning, I'm going to review some common syndromes based on the location of the stroke and the cluster of symptoms, where I will be highlighting the psychiatric related symptoms. While I will be focusing more so on those types of symptoms, I'm still going to briefly cover other symptoms that typically occur within these types of strokes, as it's important to recognize that these emotional, mood, behavioral symptoms are not happening by themselves, but can be happening at the same time and intermingling with those other symptoms. So starting us off is the MCA stroke. The MCA stroke accounts for about 2/3 of all strokes. Usually this type of stroke is caused by an embolism. In preparing us for what symptoms we expect to see with an MCA stroke, we want to think about, again, what regions of the brain are involved with the MCA. Up here in this picture, the portion that is covered in pink or red is fed by the MCA. So as you can see, it's pretty large, where it involves the frontal, parietal, lateral, and temporal lobes, as well as the centrum ovale. Listed up here are some common symptoms of a left MCA stroke, including language problems, in which a person may have Broca's or Wernicke's aphasia, in addition to other language deficits. There may also be some left-right confusion, weakness in the right face and arm may occur, sensory loss, a right visual field deficit, or homonymous hemianopia. Gerstmann syndrome specifically may occur, which involves a constellation of symptoms, including that left-right confusion, lack of understanding of the rules for calculation or arithmetic, and inability to identify fingers, and deficits in writing. Apraxia may also occur, in which someone might have trouble performing movements to command. In terms of the emotional and behavioral component, as you can see up here, what you might see is agitation and confusion, where the person might have some difficulty with wandering, restlessness, have these sudden changes in behavior or mood. They might become easily aggressive towards themselves or others. They might be uncooperative, demanding, or really have difficulty adhering to care. Insight may also be impaired or intact depending upon what region of the left MCA is impacted. And similarly, you might see irritability or an inflated mood, or you might also see depression, again, depending upon which region of the brain is involved. Overall, in thinking back to the role of the frontal lobes, if the frontal lobes are more heavily involved from the stroke, then this may increase the chance that you experience or observe various emotional and behavioral changes. For the right MCA stroke, you may also see face and arm weakness, but on the left side. Dysarthria or slurred speech may occur, in addition to sensory loss, left hemi neglect, visual field cuts, as well as visuospatial deficits or constructional apraxia. Additionally, loss of awareness of part of the body may occur as well. Regarding specific emotional or behavioral changes, you can see here that there are a lot more changes that can occur, including the confusion, restlessness, and agitation, similar to what I was just talking about with the left MCA stroke. However, you can see these other additional symptoms. So denial of deficits, different types of hallucinations or delusions, feeling indifferent or euphoric. Additionally, a late development of depression can occur as well. Aprosity may also occur, where prosody refers to the process of conveying the information beyond what is just being transmitted by the actual words that are being used. So this is essentially focusing on the non-linguistic components of language. So this includes things like pitch, intonation, melody, loudness, tempo, stress, or accent. And this is very important because understanding the emotional content and impact of the message is really incorporated into how we communicate effectively every single day. So if you think about the message of, I hope you have a great day today, that can be perceived in a very different way, whether you say it in a very positive way or in a very sarcastic way, even though the words are exactly the same. Other nonverbal aspects of language may also be affected, including understanding facial expressions or gestures, or even understanding what a thumbs up sign or a peace sign means. For the ACA stroke, again, the ACA supplies blood to the medial surface of the frontal and parietal lobes, the anterior corpus callosum, and other deep structures within the brain. There are 5 main branches, so A1 through 5. Oftentimes, the individual will also have an MCA infarct as well, where a pretty large region then is being affected. Deficits that can occur following an ACA stroke can include motor symptoms, with weakness in the legs more than the upper body. It's rarely seen in the face. Sensory symptoms are also less common, although you may see proprioception deficits in the foot or leg. Language deficits, including transcortical aphasia, mutism, and whispering can occur. Short-term memory deficits may also be present in addition to confabulation. A pathological grasp phenomenon, alien hand sign, motor perseveration, and compulsive manipulation of tools in addition to apraxia may also be observed. Regarding the emotional and behavioral symptoms, you can see here that there is a wide range of symptoms that can occur, depending on which area of the ACA that is impacted, including amotivation, which can range from apathy to mutism and severe lack of movement and talking. Abulia and flat affect and depression may occur. In contrast to that, you may see more emotional lability, euphoria, restlessness, agitation, hyperactivity, verbosity, confabulation, and impaired judgment. With the PCA stroke, the posterior cerebral artery supplies the midbrain, thalamus, occipital lobes, temporal lobes, and posterior parietal lobe. So this is a little bit different because you'll not be seeing those frontal lobe types of symptoms that we have been discussing thus far. The symptoms of a PCA stroke, as a result, are fairly different than what we've discussed because the region of the brain is more so within the posterior area. So with these types of strokes, you might see visual field cuts, difficulties with higher order processing of visual information, gaze palsy, neglect if it is right-sided, sensory symptoms such as tingling or burning, lethargy, coma, memory impairment, deficits in reading without deficits in writing, and impaired color naming. Cortical blindness may also occur if there are bilateral lesions within the striate cortex. And then also Bolin's syndrome may also occur, which involves optic ataxia, oculomotor apraxia, and simultagnosia. So you can see that this involves a lot of visual types of symptoms. Similarly, within the region of the emotional and behavioral types of symptoms, the visual hallucinations can occur, which again makes sense given the visual deficits that are heavily involved in this type of stroke. What is notable here is that there is no presence really of frontal dysfunction or really a lot of other emotional or behavioral signs and symptoms. These next couple of slides include information on other types of strokes and areas that can be typically impacted. I'm going to highlight just the emotional symptoms for these last couple of strokes, but I have still listed the other types of symptoms that can occur for your review later on. For the thalamic stroke, you may see amotivation, apathy, agitation, confusion, and visual hallucinations. For white matter disease or strokes, you might see flat or blunted affect, as well as executive dysfunction, which can result in those various behavioral and other emotional changes. For the basal ganglia stroke, this is actually the most common site for spontaneous intracranial hemorrhage. Restlessness or hyperactivity or slowness may be observed, in addition to disinhibition, impulsivity, and different types of affective symptoms, in addition to psychotic features, so those hallucinations or delusions. For a midbrain stroke, locked-in syndrome may occur, where this is referring to complete paralysis of all voluntary muscles, except for the ones that control eye movements. And then visual hallucinations may also occur with this type of stroke. For a pontine stroke, you'll see that there are not any notable emotional or behavioral changes that are typically seen. In contrast to that, with a cerebellar stroke, cerebellar cognitive affective syndrome may occur, which is a constellation of cognitive symptoms that occur in addition to mood and emotional changes such as depression, anxiety, apathy, and dysregulation of affect. Right, so now I will turn it over to Dr. McGrath, who is going to be providing additional information about psychological symptoms and depression that may also occur following a stroke.
Thank you very much, Dr. Channing. I appreciate that information. So to summarize some of the most important information Dr. Channing was talking about, it's important to recognize that those frontal areas, the frontal lobes, and how those connect with the limbic system, which involves the temporal lobes and some of the deep brain centers, those connections are what's involved with emotional and behavioral syndromes after a stroke. What can also complicate that is if someone is having difficulties with sensory functioning or motor functioning, then it might make it even harder for them to sort of compensate or manage their behavioral and emotional difficulties. I think an example Brian mentioned, which is a very good one, is that after a stroke that affects your language, if you're having a hard time talking, then that's going to make it much harder to figure out how you're going to adjust to your stroke, because part of how we cope in life is by talking to people and asking questions and things like that. So there's just an example of how a symptom like difficulty with speech can contribute to something like an emotional difficulty following a stroke. So what I'm going to talk about first here is some of the psychological symptoms that we can find after stroke or acquired brain injury. One of the things to mention is that irritability, anxiety, and depression can develop for an individual simply as they are facing and coping changes related to the injury. And it's important for a provider to have knowledge of the brain and a stroke, for example, when they're working with an individual who's having psychological or behavioral changes, because understanding the information that Dr. Channing was sharing with us helps us to identify the best treatment and helps us to provide education to an individual who's survived a stroke, as well as their family and other people who are close to them. One common phenomenon following a stroke is something called post-stroke depression. I'll give you more information about that in the following slide, but the term depression is an apt description, and the way to think about it is that symptoms following a stroke or post-stroke depression are generally similar to what you might see with major depression, meaning someone who has a psychiatric condition of depression. So these symptoms are going to include things like depressed mood, decreased interest in activities, changes in weight and appetite, so that could be weight gain or loss, problems with sleep, changes in your overall movement, so restlessness or being more slowed down, fatigue, worthlessness or sense of guilt, problems with concentration, and also thoughts of death. It's important to recognize that depression can sometimes manifest as problems with memory. So sometimes after a stroke, someone will say that they're having a lot of trouble remembering something, where in fact it might be a reflection of depression. Another thing that's important to recognize is that the symptoms I just listed of depression can also be directly related to the stroke. So an obvious example would be changes in motor movements. A person has trouble moving their body because they had a stroke. So it's important to consider if someone is restless or having difficulties initiating movement, is that a symptom of the stroke itself? Is it a symptom of depression, or is it a symptom of both? A similar concept must be considered when we look at physiological changes like fatigue, problems with sleep, changes in appetite. These are all things that could reflect the stroke itself, could reflect a mood change, or a combination of both. The other thing to keep in mind is that the cognitive problems associated with depression, such as problems with concentration and slowed thinking, could themselves reflect the stroke or a change in mood. So again, this is complicated information about the ways that the stroke itself and psychological adjustment affect one another, and is further reason to make sure that someone is able to work with a provider who understands neurologic injuries and strokes. We could go to the next slide. Thank you. So let's talk for a few minutes more about post-stroke depression. Post-stroke depression is the most common psychological or behavioral syndrome following a stroke. Its prevalence is estimated to be about 40% in the acute phase. And when I say acute phase, I mean within the first 6 months to a year. And post-stroke depression can persist for quite a while. So that's important to keep in mind. Sometimes people say, well, he or she is just adjusting to their stroke, give it time. I would warn you to be careful with that, because depression is very debilitating and it can persist for quite a while. The prevalence changes in a chronic phase, and research here is quite variable, meaning some studies find depression in the chronic phase following stroke at 18%, all the way up to 54%. The important comment here is to recognize that depression is a common syndrome following stroke in both the acute and chronic phases. Depression is really important to think about because it is associated with a higher mortality rate among stroke survivors. In terms of suicide, it is less common in post-stroke depression than it is in major depression, but it is still a higher risk among post-stroke depression patients than it is in the general population. So developing depression after stroke does increase the risk of suicide. Risk factors seem to be related to insomnia and cognitive impairment. The other thing to recognize about depression that's extremely important is that it is associated with decreased activities of daily living. Many of the things that Brian was talking about that have been important for him, engaging in activities, socializing, working hard to get better, continuing to participate in rehab, all of these things are much harder for an individual who is suffering from post-stroke depression. So in that way, post-stroke depression can hinder a person's recovery if it limits the person's ability to engage in activities that help support rehabilitation. The other thing to recognize is that following a stroke, if a person is less physiologically engaged less physically active, that in and of itself can be an independent risk factor for worse outcome following stroke. How do we know when someone is going to develop post-stroke depression? These factors listed on this slide increase an individual's risk of developing depression, but certainly do not predict who is going to become depressed, meaning an individual might have some of these risk factors and not develop depression following stroke. And similarly, someone might develop depression following stroke and not have these risk factors. That being said, individuals with more severe strokes are at higher risk of developing depression. And also, if the stroke results in poor functioning, really limits the person's ability to do things that are important to them, that increases their risk of becoming depressed. Within this poor functional status, we can refer to things such as impaired skills of daily living. So a person's ability to manage their personal hygiene, their ability to walk or get around the house, their ability to communicate, all the way up to higher level activities like a person's ability to drive or work. So the more the stroke affects a person's ability to engage in important activities of daily living, the higher the risk that that person might develop depression following a stroke. Independent of that, lower education and income status is also a risk factor for developing depression, as well as a pre-existing history of depression or other psychiatric illnesses prior to the stroke. So it is important to know someone's pre-stroke psychiatric history to help identify if they're going to be at risk of developing depression following a stroke. The same is true for a family history of psychiatric illnesses. Another independent risk factor is pre-stroke cerebral atrophy. So among older individuals, if they're already showing evidence of atrophy cognate in terms of brain tissue, and then suffer a stroke, those individuals are at higher risk of becoming depressed. There's been a lot of research about whether or not the location of the stroke is related to depression, and overall the research is somewhat inconclusive. It does make sense, and is certainly the case, as Dr. Channing was saying, that when frontal lobe and limbic systems are involved, a person is at higher risk of having psychiatric or behavioral syndromes. But in terms of depression per se, there has not been a clear link to specific areas of the brain. That being said, similar to overall atrophy, among older adults, if they have evidence of white matter disease along with the stroke, they are at higher risk of developing depression. So to summarize, what these past two slides have said is that depression is a common syndrome that develops following a stroke. It's important to consider because it leads to poorer quality of life and poorer outcomes. And there are also risk factors that we can consider to try and identify individuals who may develop depression following a stroke. So this next slide, we're going to talk about why this could be affecting the brain in terms of the tissue itself. So there are, in addition to specific brain regions that are affected after a stroke, there are also neurochemical changes involved that we think may be related to depression as well as psychiatric syndromes. One of the things that happens during a stroke is a release of corticosteroid levels, so an increase in corticosteroid levels. And this can contribute to some of the confusion a person initially experiences following a stroke. You may remember Brian was saying that when he woke up in the hospital, he remembers difficulty speaking, but also a general sense of confusion. And that is a very common symptom that people will report following a stroke. So initially after a stroke, a person might be agitated, confused, restless, have difficulty engaging in structured activities, rehabilitation, etc., in part because of neurochemical changes that occur immediately after the stroke. The other thing that can happen is that the infarction or the stroke itself disrupts the chemicals in the brain that help the nerves communicate with one another. Specifically, monoamine pathways, which means pathways involved in the production of neurotransmitters such as serotonin and norepinephrine, are thought to be particularly important in the development of depression after a stroke. Then an additional thing to consider is that the stroke itself may be affecting other aspects of neuronal functioning, such as neurogenesis, cytogenesis, and neuronal maturation. What this means, basically in English, is the regrowth of neurons, the development of synapses between neurons, and then also how those nerves mature to create functional pathways. So again, the stroke itself causes chemical changes in the brain and also interferes with the recovery process itself. So what do we do about this? How do we help individuals who have developed depression or have other behavioral syndromes, such as the ones that Dr. Channing mentioned in relation to specific stroke syndromes? So one thing that is important to recognize is that medications can be beneficial for someone after a stroke. Antidepressant medications are associated with improved mood, and examples of medications that have been studied and found to be beneficial include nortriptyline, trazodone, and a class of medicines called serotonin reuptake inhibitors. These are medications like Prozac and those other common medicines that might be given for depression. So we know that medications can be helpful in managing the symptoms of depression as well as other psychiatric symptoms following stroke. We also know that a combination of psychological interventions, psychotherapy, as well as medications is supported. Another thing that's important is physical therapy. So, and the research specifically comments on physical therapy, but I think it is reasonable to extend that to occupational therapy as well as speech therapy, meaning engagement in rehabilitation can lead to improved mood, not only because it helps to reinforce and build recovery, but also because it forces social engagement and increased activation. And one of the things that's very important following stroke in terms of management of mood and behavioral syndromes is engagement in activities of daily living. In addition to medications, psychotherapy itself is supported for the treatment of stroke. I thought it would be helpful to give a brief definition of what we mean by psychotherapy, which is that psychotherapy is an intensely personal dialogue between a therapist and an individual seeking treatment. And the purpose is to help the individual cope with personal problems or difficulties and help them in such a way that they can go on to improve their management of the symptoms even after the therapy is done. Treatment should be provided by a therapist or psychologist who has professional training in understanding neuropsychology, the syndromes Dr. Channing was talking about and how they affect mood and behavior. This treating provider should also understand the other aspects of recovery from stroke that can be challenging for an individual and should take the time to get to know the individual and their own personal strengths and values. The benefits of psychotherapy are many. One is that it can help an individual understand their thoughts and feelings so that they can come to adjust to the changes in functioning and develop a new way to think about and experience their changes they're having in their life. Psychotherapy can help foster a positive sense of an individual's capacities and overall abilities and help them identify resources available to them so that they can look at their difficulties in a new way and identify things that are going well. I think an excellent example Brian gave was that it was certainly the case that his right hand did not work as well as it did before the stroke, but it was also the case that his feet and legs were working well and he had good balance. Being able to identify those as personal strengths and resources was probably something that helped him to cope and manage changes that occurred with his stroke. Psychotherapy can help with symptom remission because if it helps someone manage their negative mood and negative affect, that can have an overall benefit on their quality of life, as well as other factors such as sleep and pain management. Psychotherapy can help with supporting behavioral activation and engagement in daily activities. Psychotherapy can provide education to family members and stroke survivors so that they understand what they're going through and maybe even can anticipate future challenges and opportunities. And then another thing that's important to consider is that psychotherapy can reinforce the health behaviors that are important when they're related to stroke prevention. We have not discussed in this lecture stroke prevention, but that is always an important aspect of treatment for individuals following stroke. So recognizing health behaviors such as exercise, healthy diet, following medication recommendations for management of risk factors such as elevated cholesterol, blood pressure, and diabetes can all be very important parts of treating an individual. This is particularly the case if someone has depression following stroke, because if depression leads to decreased engagement in activities, it can also lead to problems like not following your medication recommendations, not checking blood sugar, etc. All of those factors then leading to the risk of another stroke. So to conclude, what we have reviewed here is that different types of strokes can lead to specific behavioral syndromes as well as specific physical and sensory problems. There is a specific type of behavioral and psychological disorder following stroke that is quite common and can lead to poorer outcome and poorer quality of life, and that is post-stroke depression. And fortunately, post-stroke depression does respond well for many people in response to medications and psychotherapy. And that's very important to keep in mind because for many individuals, post-stroke depression can persist for as long as 1 to 2 years or even longer. So it's important not to sit and wait, but to instead support someone with getting treatment as soon as possible if they are developing depression following a stroke.
On behalf of Bancroft Neuro Rehab, I would like to thank you for attending the webinar. Have a great day.